Ladies and gentlemen, thank you for the opportunity to present the key highlights of the 6th Annual Global Summit on Precision Diagnosis and Treatment of Prostate Cancer, a virtual event that just took place in September this year. Annual Summit was established since 2016 by AdMeTech Foundation, a nonprofit organization and creator of the Manogram project. AdMeTech is leading national and international groundbreaking programs in prostate cancer research, medical education, public awareness, and advocacy that have been advancing patient care and reducing health disparities. Grant Rounds in Urology, a digital publication with an outreach to over 15,000 physicians, has been serving as our media summit partner since 2019. Prostate cancer is the most common and the second most lethal malignancy in men. Prostate cancer screening has been successful in reducing mortality by more than 50%. Dr. Henrik van Pappel of Belgium Catholic University pointed out that based on the annual reduction of mortality, PSA screening emerged as the most successful screening program in the history of cancer. Since 2016, our annual summit has brought together the key international opinion leaders, representing every imaginable clinical expertise to address fundamental challenges in patient care, to develop accurate diagnostic tools for improving risk assessment in order to reduce overdiagnosis and overtreatment of subclinical prostate cancer, as well as underdiagnosis and undertreatment of aggressive, potentially lethal disease. To integrate anatomic, biologic, and histologic diagnostics, liquid biomarkers, imaging, genetic cancer profiling, proteomics, standard and advanced pathology for a comprehensive approach to patient evaluation. To integrate precision diagnosis with precision treatment for optimal patient management strategies, to stimulate discovery of novel targets for imaging, biomarkers, drug development, and clinical therapeutics. Our approach includes building a multidisciplinary consensus on the best emerging clinical practices and research priorities, educating medical community and general public, and expediting transfer of promising innovations to patients. Summit 2022 program consisted of 4 sessions and 2 panels. Session 1 was focused on the population of men before diagnosis of prostate cancer. Session 2 on localized, newly diagnosed, and recurrent disease. Session 3 on advanced prostate cancer. Session 4 on image-guided, minimally invasive interventions. We had a panel on health disparities and a panel on bioinformatics, machine and deep learning, and artificial intelligence. Session 1 was dedicated to men prior to diagnosis of prostate cancer. The session's first topic was screening in 2022, and the opening lecture was presented by Dr. Andrew Vickers of Memorial Sloan Kettering. For screening, PSA is here to stay. The most important development in screening is baseline PSA testing in men at midlife, starting at the age of 45. In most men, baseline PSA is lower than 1 and indicates a low risk of lethal prostate cancer long-term, over 10 years. In the minority of men, baseline PSA is greater than 1 and predicts higher risk of lethal prostate cancer. The growing evidence indicates that baseline PSA may trump other risk factors, including race and family history, and can reduce unnecessary screening and overdiagnosis. Dr. Vickers pointed out the importance of integrating PSA with novel validated liquid markers and imaging such as MRI for improved patient selection for biopsies. His presentation also highlighted that the current risk stratification, including the number of positive cores and the percentage of cores occupied by cancer, were rendered irrelevant by imaging such as MRI. Consequently, we discussed the critical importance of novel quantitative approaches to risk assessment, such as, for example, multifactorial nomograms, taking into account information derived from liquid markers, imaging, to avoid overdiagnosis and overtreatment. In non-invasive diagnostic evaluation, we have seen a significant and rapid progress in both clinically accepted and emerging liquid biomarkers using blood and urinary testing. These biomarkers have been shown to improve prediction of aggressive prostate cancer and selection of men for biopsy when combined with PSA screening. More recently, testing of blood and saliva for germline mutations has been recommended for men with family history of aggressive prostate cancer, and I will talk about this later. In imaging, MRI and related PIRAT scoring for risk assessment have become a new standard of care. Advanced ultrasound has an exciting potential, particularly when it will be integrated with MRI. Dr. Louis Emmett of St. Vincent Hospital and Garvan Institute of Medical Research in Sydney, Australia, presented interesting data demonstrating a promising role of molecular imaging, such as PSMA, when integrated with MRI prior to biopsy. Other research is needed, however. Our panel on smart screening reviewed major clinical trials demonstrating compelling data on integrating PSA with liquid biomarkers and imaging for improved diagnostic performance and selection of patients for biopsies. During the screening panel, many urologists leading large-scale clinical trials pointed out that given all the advances in imaging and liquid biomarkers, patient selection for biopsies based on PSA screening alone is coming to an end. Liquid biomarkers can be easily administered in any doctor's office, while high-quality MRI requires specialized clinical settings. Further, liquid biomarkers appear to have a higher negative predictive value in this patient population. Most presentations showed clinical use of liquid biomarkers prior to MRI. However, more research is needed on the sequence of testing. This is an example of the randomized clinical trial in over 12,000 men with PSA 3 or higher. This was presented by Dr. Martin Eklund of Karolinska Institute of Sweden. He showed that when integrated Stockholm's retest based primarily on liquid markers, an MRI can reduce unnecessary biopsy for benign disease by 78% and for low-grade Gleason cancer by 69%. Further, he showed that when Stockholm's retest was used first, the utilization of MRI was decreased by 36%. The Stockholm's retest combines 5 plasma protein markers, including PSA, free PSA, kallikreins, prostate secretory protein of 94 amino acids, or PSP94, gross differentiation factor 15, GDF15, more than 100 genetic markers, and clinical data such as age and family history. The goal of this test is to determine the risk of aggressive prostate cancer defined as Gleason score equal or greater than 7. Dr. Caroline Moore of University College London, England, described REIMAGINE study in 334 men and showed how MRI-based screening can improve detection of clinically significant prostate cancer. She highlighted the role of increased PSA density, or PSAD, as a quantitative parameter in identifying aggressive prostate cancer in men with negative MRI. PSA density is calculated by dividing PSA by prostate volume, measured by MRI. In essence, PSAD increases the value of PSA screening in the face of increased prostate volume. For biopsies, 2 advances have been highlighted. Perineal approach, expected to reduce infections compared to endorectal access. It is currently under investigation in multi-center clinical trials. And fusion of MRI with ultrasound for a combined image-targeted and systematic tissue sampling. This slide shows the importance of MRI for identifying index lesions and guiding biopsy needles. I think it is fair to say that blind biopsies are shifting into the dustbin of history. We are proud to be leading development, standardization, clinical evaluation, and large-scale implementation of precision MRI since 1998. Session 2 was focused on localized prostate cancer, newly diagnosed and recurrent. Our speakers reviewed precision diagnostics for staging, including risk assessment, and its impact on selecting appropriate treatment, including liquid biomarkers. For example, testing for changes in prostate cancer proteome and genome, and imaging and image-guided tissue sampling for cancer genetic profiling and their integration, called radiogenomics. Our summit underscored the importance of blood and saliva tests for germline mutations, particularly for men with family history of aggressive prostate cancer, diagnosis of high risk or advanced prostate cancer, Ashkenazi Jewish ancestry, family history of other cancer, including breast, genitourinary, gastrointestinal malignancy, or melanoma. Genetic counseling is preferred before testing if family history is present, and after testing when it is positive for genetic mutations. Research on radiogenomics has been highlighted by Drs. Alan Pollack and Sanosh Poonen, University of Miami, since Summit 2016. When image-guided histology shows cancer, the tissue samples can be examined for gene expression. In parallel, quantitative image analysis, or radiomics, is performed. The integration of radiomics and genetic profiling is termed radiogenomics. Our annual summit has played a seminal role in recognizing the importance of radiogenomics for optimizing patient management strategies. Over the last 5 years, we have seen a shift in radiogenomics from the fringes of research in 2016 to the center of the discussion on the future of precision care in 2022. Emerging data indicate that the future of patient evaluation may be based on multiple integrated diagnostics coined as multi-omics. This is a case study provided by Halo Diagnostics and demonstrating the importance of integrated diagnostics. In 2011, a 60-year-old man presented with MRI-guided Gleason score 6, an elevation of PSA, which at that time was deemed to be mild. Consequently, he was considered a good candidate for minimally invasive interventions and underwent MR-guided focal laser treatment. And yet, he had repeated recurrences in 2012 and 2016. After the second recurrence, his MRI-guided biopsy tissue sample was also sent for genetic analysis, which showed high genomic risk. Consequently, he was referred for radical surgery. Dr. Matt Cooperberg of UCSF showed that 15% of low-risk cases, as assessed by standard diagnostics, including histopathology, had high-risk genomic features. Dr. Eric Klein of Cleveland Clinic highlighted prostate cancer as a biologic rather than a histologic disease since Summit 2019. He pointed out that histology is useful for detecting a small volume, low risk, low grade prostate cancer and clear-cut high-risk disease. However, histology is less useful for the majority of cases, including large volume, low risk prostate cancer and intermediate risk disease. And that's where genomic testing can make an important impact on personalizing patient care. Dr. Klein also highlighted 2 current pillars of precision diagnostics: MRI for visualization, characterization, and staging, and genomics for underlying biology and prediction of progression, metastasis, and death. Over the last few years, we have also seen important advances in ultrasound, molecular, and multimodality imaging and their potential role in patient care. Several types of tissue genetic prostate cancer profiling are available commercially, though their clinical utilization is uneven across the United States. Dr. Paul Boutros of UCLA summarize the current and future directions of liquid and tissue markers. New biomarkers must have a proven increase in prognostic accuracy compared to the standard risk assessment tools we have today. Defined as providing information on the patient's outcome with or without standard treatment. This is prognostic biomarkers. Further research is needed to determine how individual patients will benefit from specific new markers. For example, men with high volume, low risk, low grade cancer, low volume, intermediate risk disease, or men with strong family history. He also suggested that future role of new markers should include not only improved selection of patients for active surveillance, or AS, vis-a-vis treatment, but also for monitoring of active surveillance. In addition to prognostic accuracy, we need predictive value aimed at identifying which specific treatment the patient is most likely to respond to. We need more prospective trials to study these markers and how to incorporate them into predictive modeling. Dr. Stephen Rowe of Johns Hopkins provided review of the current imaging tools. MRI lesions, particularly PIRAT-3, may appear similar for benign and malignant lesions. In metastatic disease, MRI, CT, and standard bone scan cannot reliably detect small lymph node involvement or distinguish benign from malignant bone disease. He described the promise of molecular imaging with PET-PSMA, which detects prostate cancer lesion in most patients and correlates with tumor aggressiveness. Dr. Andrei Ayagaro of Stanford University demonstrated close correlation between PET-PSMA with standard histopathology for intermediate and high-risk cancers. Dr. Ashley Ross of Northwestern University showed that PET-PSMA is superior to traditional bone scan for advanced prostate cancer. On the left here, we can see that standard bone scan shows no bone metastasis. On the right, however, PET-PSMA demonstrates an extensive metastatic disease. AdMeTech Foundation supported development of molecular imaging, PET-PSMA in particular, since 2001. It has been rewarding to see FDA clearance and growing clinical implementation of this technology over the last few years. A clinical trial of Washington University, Leeds University, and Blue Earth Diagnostics showed impact of Axumin PET-CT imaging on management of patients with recurrent prostate cancer. This study was based on 2 clinical trials involving 146 patients who were all intended to undergo anti-androgen treatment, or ADT, prior to imaging. After imaging, ADT plan was eliminated in as many as 40% of men due to negative results or prostate cancer localized to the prostate bed. In general, Axumin imaging changed patient management plan in as many as 64% of men. This also included improved target definition for salvage treatment. Dr. Ashish Jani of Emory University, radiation oncologist, provided his opinion on the clinical value of Axumin vis-a-vis PSMA molecular imaging. Based on his experience and available data, Dr. Jani believes that Axumin may provide a potential edge in detecting and defining localized prostate cancer, while PSMA PET may provide a potential edge in assessing distant metastasis. However, more research is needed. 1 year ago at ASCO, Dr. Jani asserted that molecular imaging and MRI leave traditional imaging behind due to improved patient outcomes. This clinical opinion is in alignment with the data presented at the summit. As we can see here, a comparative study of diagnostic accuracy of PSMA and Axumin PET, led by Dr. Jeremy Calais, demonstrated that PSMA is superior for staging of locally advanced and systemic disease, while Axumin is superior in detecting and defining disease localized to the prostate bed. Based on the preliminary data, Dr. Hossein Jadwar of University of South California pointed out that Axumin may be also preferable for the assessment of the ADT response. This is largely based on a complex relationship between the effect of ADT and PSMA expression, which appears to depend on duration of treatment and cancer type, castration sensitive or castration resistant. In summary, MRI has become a part of standard of care and was included in clinical guidelines for staging, including by NCCN. MRI visibility is an important factor in clinical decisions. When lesions are visible on MRI, PIRATE scoring correlates with genomic, proteomic, and histologic features. MRI invisible lesions have proteomic and genomic profiles of normal and benign tissues. In intermediate and high-risk prostate cancer, MRI has modest sensitivity for extraprostatic extension and seminal vesicle involvement, but poor sensitivity for lymph node metastasis. Molecular imaging integrated with CT or MRI is superior for local recurrence and staging, treatment planning, and monitoring, particularly for detecting lymph node mets and risk assessment. We have seen emerging and exciting role of PSMA PET in intraoperative imaging for surgical guidance, and the impact of molecular imaging on management strategies, including radiation and focal treatment, as well as systemic treatment, such as ADT and other drug therapy. In summary, session 1 demonstrated advances in non-invasive and minimally invasive diagnosis and treatment. For diagnostic advances, we have seen the role of liquid proteomic and genetic markers for predicting aggressive prostate cancer and treatment planning. We have also discussed the role of genetic cancer tissue profiling for improving risk assessment compared to standard histopathology. For initial disease, MRI has become a standard for staging, though we need to see more local programs in image quality. We have seen rapid advances in molecular and multimodality imaging, and yet more research is needed. Further research is also needed for integrated diagnostics or multi-omics, radiogenomics, proteomics, advanced histology. MRI-targeted biopsies rendered risk assessment based on the number and percent of biopsy cores occupied by cancer largely irrelevant, highlighting the need for new risk assessment strategy, perhaps multi-omics-based nomograms. We have seen the importance of precision diagnostics for individualizing treatment. It is intriguing to see the emerging role of systemic treatment when added to standard care for men with aggressive localized disease. Session 3 focused on precision oncology for advanced prostate cancer. Our speakers presented a rapidly expanding discovery of prostate cancer targets for biomarkers, imaging, drug development, and clinical therapeutics. David Naynes of Cornell reviewed the role of liquid biopsy, including biomarkers, circulating tumor cells, DNA and RNA for patient evaluation. Multiple speakers demonstrated the role of molecular and multimodality imaging for staging and treatment planning. Treatment, as mentioned, Summit pointed out the importance of molecular imaging for improving patient selection for ADT to avoid iatrogenic castration resistance and decrease morbidity. Dr. Daniel Petrilak of Yale highlighted the importance of precision diagnostics for precision treatment. He described how detecting germline and somatic homologous recombinant repair or HRR mutations, including BRCA1 and 2, for administering PARP inhibitors. He also pointed out that about 15 to 25% of his patients currently undergo precision treatment based on precision diagnostics. We have also seen the emerging role of immuno-oncology, though further work is required for consistent patient outcomes. Dr. Jeremy Calais pointed out the importance of PSA imaging for selecting patients for lutetium PSMA treatment. Dr. Philip Koo of MD Anderson, presented current state of the art and future vision for theranostics, integrated molecular imaging and treatment. This targeted radiotherapy using PSMA represents an exciting new option for metastatic disease. Current data indicate that lutetium-labeled PSMA improves patient survival while decreasing morbidity compared to chemotherapy. Session 4 of our summit demonstrated growing evidence that image-guided minimally invasive procedures provide comparable cancer control with significantly reduced complications compared to standard treatment. Precision diagnosis is critically important for risk assessment and patient selection for image-guided treatment. While MRI has been used most extensively, we have seen the emerging role of advanced ultrasound, molecular and multimodality imaging, and radiogenomics, multi-omics for target definition. More research is needed for improved patient selection, monitoring, and outcomes. Almost every speaker in the session highlighted the importance of definitive randomized clinical trials for shifting focal treatment from the current experimental stage to routine clinical care. AdMeTech has been leading development and clinical evaluation of image-guided minimally invasive treatment of prostate cancer since 1998. When validated, it will become an important future addition to the patient management options, particularly for many patients who end up in a gray zone, where risk assessment leaves clinical questions regarding the appropriateness of active surveillance or necessity of the immediate radical treatment. We hope to see an increased pace of the clinical validation and adoption of minimally invasive treatment in the near future. Our health disparities panel showed that MRI is of particular importance to Black men who are more likely to have cancer lesions in the anterior prostate, not accessible by blind systemic biopsies and digital rectal exam. This panel acknowledged emerging data on the biological differences in early stages of prostate cancer between Black and white men. However, based on a large-scale study from veteran administration and military medicine, our expert concluded that equal access to care is the key factor in achieving health equity. Multiple experts from urology, radiology, and industry pathology underscored the importance of digital health, bioinformatics, machine and deep learning, artificial intelligence for every aspect of patient management, screening, diagnosis, predictive modeling, treatment planning, care, and follow-up. There was a clear consensus that the era of only cognitive data analysis and traditional patient information management is over. Bioinformatics and machine learning are expected to be important not only for clinical practice, but also for clinical research and trials. For example, by creating and analyzing patient registries or validated data sets. Quality control of clinical data will be central to successful implementation of multi-omics, information collection and analysis for both patient care and research. Our summit was made possible by the state of Massachusetts, the Donohoe family, and our sponsors, including Platinum sponsor, Telix, Gold sponsors, Amgen and Philips, Silver sponsors, Blue Earth, Lantheus, Exosome Diagnostics, Siemens, Bronze sponsors, AAA, Johnson & Johnson, EDAP, Exact Imaging, Profound Medical. Exhibitors, Canon, OPCO, MDX Health, Veru, and Grant from PHRMA, and our governing and management team. Please join us for the next virtual summit taking place on September 21 to 23rd in 2023. You will learn about the cutting-edge clinical advances and take part in creating a roadmap for the future of precision care. Thank you for your attention.